Good afternoon, everyone. My name is Hamid Younis, and I lead Taylor Wessing's healthcare practice, both in the UK and with colleagues around the world as well. I'm going to act as the moderator of this session called Healthcare Technologies, and I think the first thing to say is apologies from Francis White, who's the Europe manager for AliveCore. He's delayed, I think, in San Francisco, which is, and it's that time of the year when you can see the Golden Gate Bridge, so there's a good excuse for him to be there, so that's all right. As Lawrence mentioned earlier today, at Taylor Wessing, and this is the little advertisement for Taylor Wessing as well, we have a very extensive life sciences and healthcare practice which covers most of the countries around the world. A lot of clients in the life sciences area, pharmaceutical, protection, intellectual property, and so on, but also in the healthcare area. And we've seen, in the last few years, a prevalence of Indian companies coming into Europe, and also companies from here going into India and joint venturing on very sophisticated healthcare projects such as proton beam therapy, or indeed in some of the IT kind of sectors with healthcare apps and so on. I think we've got some great speakers today who will give a little feel as to why healthcare is so important in terms of the development of not only the social infrastructure but the fabric of a developing country and a country that is pushing its economy as far as it can. The first speaker I'm going to go to, without saying too much more, is Dr. Babulal Sethia. He's a consultant congenital heart surgeon at the Royal Brompton Hospital, and throughout his career has maintained a commitment to the development of healthcare initiatives in low and middle income countries. And I think his subject today is technology and equality in healthcare, with a particular provision and focus on India, of course. He's worked around the world, Africa, Asia, South America, and indeed, very interestingly, in Palestine for over 16 years, helping to establish cardiac services in Gaza and the West Bank as part of a multinational alliance. I think there's a lot more we can say. Perhaps we can develop some of this later on in the question and answers session. I also tested him over lunch to try and get two things he's done in the past into his presentation, and that is he's a music buff, a percussionist, and indeed plays the kettle drums. So let's see whether he gets anything on that. And in a past life, he also ran a wine company. Now, I want to know why he stopped doing that and whether that has any relevance to healthcare. So, Babulal, over to you. I think it's this one.
Okay, super, thanks. Well, thank you, Hamid. And first of all, I should start by thanking the organisers for inviting me to talk here today. This is not my usual sort of activity. I usually find myself in medical healthcare conferences where everything is hugely technical. And it's been very interesting this morning to hear the discussion both from Ken Clark and then the subsequent session on education afterwards. And I think this session on healthcare follows on very appropriately from the discussion on education, because education is the foundation of good healthcare all around the world. You see it not just in India, but you see it as you travel around the world. And many of you in the audience will be well aware of the economic benefits that derive from having a competent healthcare system. Some people estimate the increase in GDP that can be achieved from good healthcare systems as being an increase of 1% of GDP for every 10% improvement in healthcare. But let's go to India, and I speak today really in my capacity as president of the Royal Society of Medicine, which is an educational charity. And I was interested to be asked to talk to this audience, although the initial invitation was to talk on things like what can Google do for the next generation of healthcare workers. I didn't really feel able to talk to that. But addressing the issue of how can technology address inequalities in healthcare, I think there's the starting point is really to tell you something about the current situation of healthcare in India. And in essence, healthcare in India is still in crisis. As you see in this slide, there are very poor basic indicators of health. Now, you will have seen in the news items recently discussion of the outcomes of the Millennium Development Goals. And India lags behind many other countries, much more so than one would have expected from the size of the country and the competence of the economy there. Specifically, you may not know that 1 in 5 maternal deaths around the world occur in India. These are deaths following pregnancy. And 1/4 of all child deaths in the world, that's children under the age of 5, die prematurely. 1/4 of those occur in India. The mortality rate in the under 5s is about 69 per 1,000 births, which is a huge figure for a country which, as many of you in the audience will know, actually have some very strong elements within the healthcare system. But the problem is largely that these elements are not available to the population as a whole. And it's perhaps surprising at a time when we've passed the eradication of smallpox in India amongst most of the world. There are only 3 countries in the world where smallpox is still an ongoing issue. Where polios are still an ongoing issue. But there's poor immunization take-up in large parts, particularly in rural India, where as many as 70% of the population may be missing immunization against diphtheria, pertussis, and similar diseases. And as you'll see as we go through this presentation, infectious diseases are still a problem in some areas, although less so than before. But the real time bomb, and I was talking to Pratap Reddy, who's the chairman of Apollo Hospitals, a big private hospital group in India. I was talking to him the other day, and he regards the explosion of non-communicable diseases. These are the diseases, heart disease, diabetes, the diseases of lifestyle, essentially. The explosion of that, he thinks, is going to be completely unsustainable by 2020. So not very many years to go before something has to give. And when you look at the demographics within the population in India, you see a fairly consistent picture. I don't know if this thing works. Yes, if you see here, this is the population in 2001, and then moving on 2010 and predicted in 2020. And essentially, the size of the rural poor and the rural middle class is around 60% of the healthcare population. Now think of that when we talk about healthcare, and we think about the high-tech things that will sort of intrinsically come into mind when we talk about technology. We think about that, and these people cannot access that type of healthcare. And if you look then at the issue of non-communicable diseases, the diseases are ever expanding around the world, and India included, you see that the incidence of these in the poor population is very high. And actually, while this is all going on, the urban rich get richer and the rural poor get poorer. So there's a conflict here between the availability of technology, and of course technology is often increasingly more expensive, but certainly a conflict between the rural and the urban populations. So what do I mean when I'm talking about technology for the purposes of this discussion? I've defined it as the application of scientific knowledge for practical purposes, the idea being that at the end of using technology or implementing technology, we should have a practical outcome, in this case, beneficial to outcomes in health. So we contemplate things like medicines, modes of delivery, and complex therapies, and then, of course, diagnostic issues. And of all those things, diagnostic modes and complex therapies are most obviously come to mind when we're thinking about healthcare technologies. India, of course, has many competencies. Large pharmaceutical companies, for example, the development of generic medicines, which have transformed healthcare not only in areas of India, but in other parts of the world, notably sub-Saharan Africa, and specifically in the management of AIDS and the antiretroviral therapies that go with it. But basic within the health system, within any health system, this is determined by the architecture. How is the health system set up? And 3 areas come into mind. These were succinctly described in a paper in 2010: availability, affordability, and the adoption of technology. All of these 3 things are interrelated. For example, a new agent can become available But if it's not distributed in the right way, you may get surplus in one area and yes, lack of availability in another. In India, out-of-pocket expenditure accounts for about 71% of healthcare costs. Now, this is within an economy that spends just over 4% of GDP on health, and where only just over 1% of GDP is actually provided by the government. So very low expenditure on health, and of that expenditure, 3% or thereabouts is provided by the private sector. So a lot of healthcare in India is unaffordable to large parts of the population. And of course, if you provide healthcare technology that is not liked or not appropriate to the end user, then the adoption of healthcare technologies will be limited. To give you an example of that in another dimension, a contraceptive implant for ladies was promulgated, Norplan, in the late 1990s. It involved inserting a patch under the skin of the patient, and then the patient would have effective contraception for a number of years. But within 6 years, the adoption of this was discontinued because people didn't like having the implant removed at a subsequent procedure. And indeed, in a place like the rural population of India, there were not people available technically to do that particular procedure. So it is very important that when we're thinking about technology in healthcare, we're thinking about appropriate technology, a technology that be utilized. In this country, we talk about robot surgery, for example. I was hosting a meeting last night on elements of that topic. And it's no good producing robots unless those of you who are fans of the film Elysium want to take that up. But it's no point producing robots if they can't be utilized effectively. They're just a waste of money. So when we're thinking about these three items, they come within the architecture of healthcare. Manufacturing issues are largely overcome, certainly in certain areas of Indian healthcare. I mentioned drug therapies, pharmaceuticals. India is the biggest world producer of lens implants for cataract surgery. If any of you have had cataracts operated on, I suspect not, because you're all such a young audience. But any of you having those in this country probably have an Indian lens implanted. But there are other issues like storage and distribution of technologies, which often result in unequal diffusion of healthcare, largely on account of socio-economic barriers. So the message coming from that is whatever healthcare technologies you develop, and however sophisticated they are, they're of no use whatsoever if they can't be utilized by the end user. Let's switch tack a bit, and I don't expect you to read the writing along the bottom of this slide, unless you're really a superb airline pilot or something. But this is a slide showing the distribution of client platform usages for various transactions in healthcare. The various transactions are listed along the bottom, and they include things like diagnosis, treatment recommendations, and so on. And the point of this is that in India, at least this is 2011 data from the International Telecommunications Union, most of the, as it were, telemedicine type of interactions were conducted using laptop computers of one sort or another. Mobile phone technology is right down here at the bottom of the graph. And we heard at the moment how mobile phones are becoming more and more accessible. And indeed, I've no doubt at all, and we'll come back to this point, that the use of mobile phone technology has to be one of the platforms for creating access to healthcare, particularly for the rural population. Switching to another element of healthcare, this is data published in The Lancet, which is a medical journal quite well regarded in the global health area. And what it shows you is data on the percentage of what we call disability-adjusted life years. It reflects the number of years lived with disability, and it's in two time frames. Up here is 2001 or thereabouts. Here we're coming up to 2013 and 14. And all I want you to focus on India here is the color has changed. In the earlier time frame, the number of people living with significant long-term disabilities is about 15% of those that are alive with some sort of disability. But over time, this is changing. So we have now 25 to 30% of people living with long-term disabilities. the impact on the health systems are huge, because you're now dealing with chronic disability, inability to work, and yet within that system one has to be able to survive, and often the spin-off for families in that situation are particularly terrifying. And if you look at the changes in the things that are causing these problems, and again, don't focus on the detail of this slide, but it just shows you percentage change over the last 20 years or so. Most of these items above the line, this is where you get a worsening of the overall outcomes, relate to areas that are essentially non-communicable origin: ischemic heart disease, HIV and so on, diabetes, cirrhosis, which is largely promulgated by alcohol abuse and so on. Some small improvements in some elements of healthcare, but many, many difficult areas to pursue. And again, in this slide, just focus on the two top things that could actually improve the outcome, and that is attendance to household air pollution issues. This often comes from cooking stoves and in the rural areas, and smoking. So lifestyle changes. You don't need very fancy technologies in order to actually influence outcome options in healthcare. Now, when one thinks of computers, we often, when we think of healthcare technologies, we often think of computers. And of course, the aspiration ultimately, and I mentioned Elysium, which is a film for those film buffs amongst you that haven't actually seen it, where humans of a particular type that can go to another planet actually have all their illnesses diagnosed by a computer scan fixes it immediately. This is not available on the health service for any of those that are here. But the aspiration is obviously to diagnose as much as possible online. Artificial intelligence isn't entirely there yet. Doctors like to think that we have a certain amount of intelligence. Some of it at times you could label artificial, but that's perhaps a point of debate. But computers are useful in healthcare in terms of competitive procurement, in terms of putting up information on pricing, which affects issues of competition, and in particular, and I would say this coming from an educational charity, in the provision of cheaper online education. And we heard something of that in the preceding session earlier this morning. This is a schematic produced by Apollo Hospitals, which is a large private healthcare provider. They have 53 hospitals in India. And what it depicts is really the application of telemedicine, which can be used in a variety of ways for long-distance consultations, quality assurance issues, and of course, very importantly, continuing medical education and training. And they have projects which reach out from central hubs into areas of the country that are very difficult to access. But having said that, India is a large place, as you all know, and they can't yet, or at least haven't yet, managed to get through all the challenges there. So when I think of how technology might be used to reduce inequalities in healthcare, I'm minded of a comment that I heard from Kofi Annan when he was Secretary General of the UN. And there's, in my view, I think this holds very relevant in this discussion. And the first thing is political will. We heard a lot about Mr. Modi and the aspirations for his future government. And I have to hope that, amongst other things, and right at the top of the discussion is the political will to actually do something about healthcare, especially in rural India, and thereby to reduce the inequalities that currently exist. Intersectoral collaboration between the private and public partnerships we've heard a little bit about today. I fully endorse a view one member of the audience this morning, because certainly in the experience that I've had in international health and forging partnerships of one sort or another, there has to be value on both sides, and it has to be a true partnership in order for something to work effectively. Amongst that, as I indicated, the current expenditure on GDP is still very low in India, and you might reasonably expect that if we're going to see an amelioration of that problem, that GDP figure's got to go up. I mean, in the UK at the moment, we're sitting at about 8.9% of GDP. I'm not suggesting for a minute that we jump up to the 18% that you see in the US, because that's also unsustainable. But we also have a commitment to education, and I think education and political will are the two key points in this analysis. If I were to take the most single important point within that debate, I would say education is the single most important technology in combating healthcare inequity. But it has to be combined with the adoption of effective communication, by which I mean communication that can really be taken up and understood by the recipients of these interventions. We heard this morning about how difficult it might be to interact with, I think it was a 34-year-old who has no familiarity with computers. But mobile telephones and the expansion that we're hearing about in mobile phone technology, I think offers a different opportunity. And if you look at the analogies in East Africa and in the financial sector in the use of mobile phones, not only, I think, will that affect the delivery of healthcare in India, but I think here in the UK, we'll have a lot to learn from it. And talking to the chair of NHS England the other day, I noted that one of his particular interests was how can the UK learn from countries like India in mobile technologies of this type. But don't forget that the socio-cultural as well as the political factors are fundamentally important. You can't, and again, going back to this morning's discussion, the differences between states in India mean that there's not necessarily an absolutely one-size-fits-all solution to this problem. Nevertheless, I have to hope, and I do actually think that there are ways of working around that if there's the political will to do so. And in terms of education, we heard a lot this at the previous session, experiential learning. What we need is not just educational material, not just the didactic approach to education, but education that comes of experience and also that is transformative. In other words, has a reflective element to it so that people can actually see and build on the benefits that they learn with regard to healthcare technologies. I've already alluded to the importance of the use of, in particular, mobile types of communication, but we need to see more active, interactive health promotion programs, and that particularly is relevant when we're talking about preventative care issues. Alcohol abuse in India is an increasing problem. Tobacco abuse obviously is in conflict with the financial imperatives of some multinational companies who see low middle income countries as a justifiable target for achieving their profit objectives. But if one can attack these healthcare problems by engaging in the educational agenda, I think we can do an awful lot allied to the technical developments that we see around us. So I will leave you with some thoughts. First of all, that developing a safe and effective technology is necessary, and technology changes all the time. It's not fixed in time, and therefore one has to be careful about how one invests in that technology. We don't necessarily need the most expensive technology in order to do the job, and I'm sure that Jaideep Prabhu may have something to say about that in a follow-up session. But you can have the technology, but it's no good, it's not useful if it can't be accessed and worked with. And this conflict, or this putative conflict between vertical developments in technology and the drive to really reduce inequality in healthcare, I don't think there is inevitably a conflict between the two. I think it's more a question of how you make these technologies, some are more sophisticated, some, as you've heard, are less sophisticated, but how do you integrate them effectively? And for that, I go back to the issue of political will. We've heard, of course, about some of the practicalities in India, the issues of power, the issues of portability when we get into diagnostic facilities, although these are becoming more and more portable as time goes on. And of course, as we increase the use of technology, issues relating to data security, personal ownership of data, and so on, in the context of increasingly personalized medicine becomes absolutely valid. But none of those are absolute impediments to developing a much more comprehensive healthcare opportunity I think, for the whole population in India. So these are the goals that are set in the most recent 5-year plan to promote universal health access in India. And of course, the Sustainable Development Goals that will be coming out later this year, all being well, or, to follow on from the Millennium Development Goals, these are the things that have to be attacked. Improved financial access. Well, that's a function not just of the individual, but it's a question of how the state, how the government, whether it be state government or national government, how does it actually engage with that? Filling healthcare resource gaps. India is quite innovative in some aspects of it, but remember, if you look at the village workers or the ASHA program or things like that, you've got large numbers of workers, maybe as much as 1 million healthcare workers of one sort or another, but there's no quality control within them. And in fact, there's no serious quality control in large parts of the healthcare sector in India. And something has to be done about that if the resources are to be used effectively. Overcoming workforce shortages. Again, a political problem. It's interesting, isn't it, that if you look at nursing colleges in India, they're limited to an output of 75 nurses per year per college. If you look at the medical sector, it's 275 graduates per year. There are 650,000 doctors in India. That's about half the projected need. And if you think that in the UK, there are just over 200,000 doctors, just to put it in context, and India is rather larger than the UK, that shows you something of the shortage there. In terms of social issues, greater healthcare spending and lower out-of-pocket expenditure, absolutely achievable if there's the political will and if the public are enabled to access health in an appropriate way. The quality agenda, which must be patient-centric. I think this is gradually coming into the scheme of things, certainly in terms of some providers, but there's not yet an integrated approach between the public and the private sector. And even within the private sector, and many of you in the audience will know better than I am, of some variations between different private healthcare providers, there are issues to deal with there. So a lot of challenges in providing more equitable access to healthcare in India. But the use of technology, combined with an educational approach, I think, can promote significant progress in this area. And I do hope that the current government of Narendra Modi will be a path to that end. Thank you very much.